already mashing it.
So today we're going to talk about decreasing catheter utilization on acute care units. How often are Foley catheters inserted, do you guys think? According to statistics, approximately 30% of our patients in our entire nation have Foley catheters during their stay. So why do we need a change? Well, in 2012, due to the increase in cost, length of stay, and infection rates, hospitals were challenged by CMS, or the Center of Medicare and Medicaid, to decrease patient harm associated with urinary catheter infections, or CAUTIs. Those are called one of the never events. There would be reimbursement tied to this, so it kind of encouraged hospitals to decrease these rates naturally. They said, hey, this is our problem, we need a solution, you guys handle it. So they weren't dictated on how they had to do it or who had to be involved, so hospitals could come up with whatever ideas they wanted just to drive these rates down. We also call these device days. So, what is the evidence-based care? You're going to hear me talk about that a lot during this presentation. Evidence-based care is simply what shows works. It is providing the best patient care while they're in-house, being the most cost-effective, and ultimately yielding the best patient outcomes. It works to reduce variation in patient care by creating a standardization. So what we're going to learn today is what happens if we place unnecessary Foley catheters. When is it appropriate to place a Foley catheter? And then we're going to learn a little bit about nurse-driven protocols driving the utilization rates down. So what could it hurt? Why does it even matter if we put in Foley catheters that aren't necessary? Well, when we insert a foreign body or a foreign object into the urethra, which goes up into the bladder, it increases the chances of bacteria being introduced, resulting in CAUTIs or catheter-associated urinary tract infections. The CAUTIs can also happen if we leave the urinary catheter in for too long. The bacteria can go, like if we're not doing necessary pericare, it can go from the side of the leg or on the bed, because let's face it, hospitals aren't the cleanest. It can travel from there up the tube and into the bladder that way as well. Hospitals have been challenged to decrease our catheter days, thereby decreasing the CAUTIs, cost and mortality. It also increases your length of stay. So if a patient comes in and that we insert a Foley catheter out of convenience because the patient themselves don't want to have to get up to go to the bathroom, which we do have in our patient population. They come here for something like, say, with their respiratory system, and then we introduce bacteria, or they get a UTI because they've been laying in the bed and don't want to have to get up, then we've just increased their length of stay and their costs that they've incurred. CMS says, well, we're not going to pay for that because you guys did that. Shame on you. They say if you shouldn't go to the hospital and get sicker, which is exactly right. So we get points counted off for that as a hospital, as a facility, and as a nation, and we should. It also increases the risk for mortality. Our average patient age is about probably 68 to 72. So they already have comorbidities that are counted against them. You know, they have COPD, they already have CHF, they have pneumonia most of the time when they come in. So if we give them another infection to put on top of it, it increases the mortality. So when is it appropriate? In preparing for this educational session, I did a lot of research on the internet for peer-reviewed journal articles, and one of the easiest ways that nurses can remember the indications for a Foley catheter is the Houdini method. So H stands for hematuria. So if a patient comes in and they're having a lot of bleeding that could lead to clots and create an obstruction, then that's an indication that we can put a Foley in. A urinary tract obstruction is another indication. So we want to keep that free so that we don't have buildup and cause problems later on.
Line 400, please.
Urology.
Line 400.
Urology surgery could be another one, like if the patient goes in to have a TURP or a procedure done that's specific to the urinary tract, they would need to have a Foley catheter placed for observation and things like that. Decubitus ulcers on their bottom, sacral wounds that are stage 3 or greater, that's an indication that we can put one in so that you can check a box for that. Intake and output monitoring, but those are only in critical care situations. We as a hospital do not take care of critically ill patients. We don't have an ICU, so none of our patients should ever meet that criteria. These are patients with cardiac drips who are on ventilators, who can't get up, and we need to monitor them. A no code is another one. So if a patient comes in on palliative care, they're a hospice patient, and they're actively dying, they're a DNR, and they don't need to get up for comfort reasons, we can place a Foley catheter and safely keep it in them. And then immobility would be the last one. So what do I mean by immobility would be orthopedic patients who got in a bad car crash and their entire pelvis is crushed. They're gonna have to lay immobilized for an extended amount of time. So we don't want their bottoms to be wet and become excoriated and have breakdown from that. Or spinal surgeries would be another prolonged immobility. So how can we as nurses affect change with this?